Guys, it's Mrs. Lewicki, and I'm going to talk to you right now about documentation. Now, you are going to have a documentation assignment, and you will have plenty of opportunities throughout the program to actually demonstrate documentation. So why do we document? So many of you guys are all already LPNs, so you know that why we document is that's our way of communication. So we communicate, we discuss. There's reports, there's records. All of that is part of documentation. It's a legal record. It may be referred to as the patient chart or the patient record, and it follows specific policies and guidelines depending on your agency, what gets documented and how frequently that documentation occurs. So there are legal and ethical things that dictate how we document and what we document. The first and foremost being that it's important for us to maintain confidentiality. The patient record is their private record. It's legally protected record, and there's restricted access. The healthcare facility, whether it's the doctor's office or the hospital or the nursing home, they own the record. The record belongs to the healthcare facility, not to the patient. The patient can request a copy. Some places are very open now. There's been a big push for that, being open to have your own records, but they are currently the property of the healthcare facility. They fall under the HIPAA guidelines for confidentiality and protection. And part of the way we maintain confidentiality is through password protection. Nurses need to sign out of their computer when they walk away. Duplicate or unnecessary documents need to be shredded. When you are in clinical in the hospital as a student, sometimes the nurse, really for their convenience, will print you a copy of labs for your care plan and for whatever reason, but basically so you're not taking their computer. And we insist that you must shred those before you walk out of the hospital because that's an ethical, a legal obligation. Patient records are the communication of care between the professionals that are planning care. So whether it's the physician, the physical therapist, the nurse, everybody communicates in that patient record. We use them also for auditing purposes. Are vital signs being done as frequently as they should? How is that new medication going? Are we tracking any side effects? Research, education, and they also use them for reimbursement. And we'll talk about that more as the course progresses, but part of, you will hear often said, if you didn't document it, you didn't do it. Well, that really applies in reimbursement. If the patient had an IV and they get billed for the IV catheter and the IV fluid and the IV tubing and all of that, but you never documented that you started an IV, then they don't get reimbursed for that. So those are important things and part of why we. So there are different ways that we document, and most places have gone to some kind of electronic record, and that is the law that we have to go to electronic records. I see the electronic records in my doctor's office, most of them, in the hospital. There's different systems, but they all really comprise the same type of information. It's just how you get the information in there that changes. So the first few things that I'm going to talk about are paper documentation. So source oriented, that's our typical old style chart where you flipped it open and here was a graphics section, and here's the MAR, and here's the doctor's orders and the progress notes. And it was divided by departments, and most of them were written as narrative notes. Problem oriented is arranged by the problem rather than the source. One of the things that in how we documented in problem oriented was called SOAP notes. You'll sometimes hear that, or SOAPier. And so you would say subjective information, objective information, the assessment, and the plan. And if it's SOAPier, that includes interventions, evaluation, and revisions. And so sometimes we'll ask you to do that because one of the areas that we've noticed as students progress through the program, and this has been an ongoing issue, is you're not often able to document in the facilities or minimal documentation. And so when we see you in SIM, we want you to document, but you're still unsure of that as a process. And so sometimes we'll have you write a narrative or a SOAP style note. So you may hear that term again. The PI model is problems, intervention, and evaluation. We'll do focus charting sometimes, and I've been a nurse for a long time, so I've seen all of this come and go and get back in style and go again. But focus charting is when you're just focusing on the condition. They came in to get their gallbladder out, so every single word in the chart is about their gallbladder and the surgery related to that. That has its limits because sometimes it misses things that also are happening. A lot of times we'll do charting by exception, and basically it says, I'll stick with the gallbladder patient, but it'll say you'll have a protocol that says this patient will be up, they'll be having a clear liquid diet, their IV will go to a saline lock, and blah, 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 along that path. But now they're throwing up. So that's the exception. That's not an anticipated finding. So then I document about the vomiting. So when you're charting by exception, you're only charting the abnormals, but you are documenting throughout the shift that everything was fine, as expected, maybe not fine. Sorry, I didn't finish filling out that bottom line, but electronic charts are replacing other methods of documentation. And so all of them will have all the same information, like I said, but it's how they label it that's different. Case management is another type of care and style of documentation. It's high quality, cost effective care. Case management tends to be interprofessional or interdisciplinary, and we follow critical pathways. And like I said, the gallbladder patient. So was it an open gallbladder surgery or a closed gallbladder surgery? And whatever happened, that's the pathway that we follow. So typically we want them to be closed procedures now, which means laparoscopic rather than cutting an incision. So it's a closed procedure, so expect their care and their progress to follow a timeline, a typical timeline. And all of the professionals are there to help them keep them on that timeline. It does include graphs and flow sheets. And then if they're not, or they fall off the pathway, or they aren't meeting whatever goal they should be at, then there's variances are documented, and we try to get them back on the pathway. And that's when we also involve other interprofessionals and disciplines to help get them back on the pathway. Other documentation includes nursing activities. We always want to document ongoing status. Like I said before with the charting by exception, you are still charting, documenting that you're checking on the patient and that everything is going as expected. That's an ongoing status. They're sleeping, they're sitting in the chair, whatever it is. They should reflect the full range of the nursing process, so it should have assessment. And we'll talk about the nursing process in a week or so, but it should have assessment. It should have data collection. It should have interventions and evaluation. All that should be in there at some point. We'll talk a little bit more about admission assessment in a minute, but the admission assessment is a nursing activity. The plan of care, or the nursing plan of care, a lot of hospitals have gone to an interdisciplinary plan of care, and we'll talk about that in a few weeks. Flow sheets. Flow sheets usually involve, like, if I'm checking pulses every 15 minutes or vital signs. Progress notes, discharge and referral summaries are all part of nursing. Long-term care and home care is also part of the chapter, and it's usually skilled or intermediate care, or when they can be cared for at home with a caregiver, or sometimes an intermittent care of a nursing professional, or respiratory or physical therapy, whatever healthcare professional. Documentation is based on professional standards and federal regulations, and how frequently you document, whether they're in the hospital or long-term care or home care, is really going to be dictated on the current condition of the patient and the hospital-specific policies. So, for example, a post-op patient, in that initial 24 hours, I'm doing vital signs and documenting more frequently than I am on that patient that came in with pneumonia that is receiving an IV antibiotic but is stable. So all of that's going to vary depending on your patient condition. Home care also requires a home health certification, a written plan of treatment, and any medical updates as part of their documentation. Here's some general guidelines for you. I've said this already, but documentation is confidential and it's a legal document. All entries should include the date and time, your signature, I think I said that twice, and only use a hospital or agency approved terminology. That it doesn't seem to be an issue like it was when I was growing up as a nurse because of electronic records. Do not chart before you've done the task. Make sure you use correct spelling. Sign it. I said that already. It should be factual and objective observations. You really should avoid subjective data unless you're putting it in quotes, and we'll talk about that in just a minute. No opinions or interpretations. They seem to be fighting. You don't want to say that. You could say their voices were raised, but even that's kind of iffy because my raised voice is different than my husband's raised voice. So some of that is still subject to interpretation, and you don't want to get into that. You want to make sure that your documentation is sequential in the order events happened. It's appropriate for the situation, that it's complete and brief at the same time. Some do's and don'ts. So you do want to document any changes in the patient's condition. You do want to read prior notes so that you know that there was a change in the condition. You want to make sure it's done in a timely manner. Objective, not subjective. And I'm going to skip the line there. But if it's subjective or the patient is saying, my pain is a 10 out of 10, or the hospital's not taking good care of me, you want to say, patient states, or Mr. Jones states that, whatever it was, because it says don't use patient in lieu of name. You want to correct any errors. You want to document any responses to treatments, medications, any therapies, and you want to make sure that you're ensuring clarity. When you're looking at the medical record, you want to look at it with an eye of, if I have to read this chart in court in 3 years, in 5 years, in 7 years, am I going to know what happened? And when I talked about the different types of charting, we had the charts divided by departments, it was a whole lot easier with the nursing department in its own little place to actually see what I did as the nurse during that shift. It's a lot harder now with electronic health records. So you want to make sure that you're clear enough that you can follow it later. The other thing is you want to make sure that you're clear enough and consistent. So if you're saying that they're having pain of 7 out of 10 in the pain section, but then in the med section you say their pain was a 5 out of 10, even though that was likely just a typo, somebody's going to pick that up and say, well, what is it? Is it a 5 or is it a 7? So you want to be really clear about that. Some don'ts. Don't chart before you actually do the task or the event. Don't use vague terms like arguing or you seem to be in pain or whatever. You want to be careful about your language use. Don't ever chart for someone else. It says don't use patient in lieu of name. So you would say Mr. Jones states. Don't ever alter a record, and don't record any assumptions. You can document, let's say they're telling you they're not having pain, but you're watching them grimace and then you prod them a little bit more for, you're making these facial expressions. Are you having pain? And you can document that, but you have to be careful about assumptions. And I don't know if that was my best example, so I'm trying to think of a better example for you. I can't come up with an example, a better example of an assumption. One is if somebody has a hijab on, don't assume that they're vegetarian. You want to ask questions, and you don't write in the chart that they're vegetarian because they have a hijab on. You want to make sure that you have talked to the patient about that. That probably wasn't my best example, but that's the end of this. Thank you.